Perfect.
Yeah, we should get started.
Yeah, that's fine. I fully anticipate this will be a rolling presentation, and I will send, I haven't done so yet, but I can certainly send a PDF copy of my presentation so that if for some reason you don't catch what I'm talking about in terms of a reference, you can actually look it up yourself afterwards. And even the video, you can actually find it on YouTube. So for anyone who wants to see it later, or even if you want to use this lecture for teaching others, you certainly can do so. If you do use the slides or copy the PDF, please keep the attributions. I've tried to give attributions to people who've actually developed the slides. This is really a compilation of a number of contributions. So by way of introduction, I'm Karin Neufeld. I am a professor in the Department of Psychiatry and Behavioral Sciences. I have had a number of interests throughout my career, and most recently, my interest has been in the study of delirium because I have been in charge of the consultation service at Johns Hopkins Hospital and now the Johns Hopkins Bayview Medical Center. I have been responsible for seeing patients on the medicine and surgical sides, and often the question is really one of delirium. People come to the hospital with something else and they call for a psychiatry consult for sometimes obvious delirium, sometimes they don't know what they're looking at. And it's a really important condition that I'd like to talk with you and share with you a little bit about what we've learned and what we are learning as we go on. So probably the most important thing is that we, as far as disclosures are concerned, don't really have any financial disclosures that you need to know about. I will be talking a little bit about haloperidol and some other medications that have been used in the treatment of delirium. These are not FDA approved, but we will discuss that. It will become evident. And I also have some other relationships as far as nonprofit organizations and organizations that I run in relationship to the study of delirium. So for today, I'd really like to get my ducks in a row. And what I mean by that, that's really a euphemism that just means I want to get things in order, and I want to make sure that in all the things that I say that you understand when I'm really trying to get something conveyed to you. And so I've got these little baby duck slides. They sort of note that I'm hitting one of these high points. So to start with, I want to define delirium and related conditions for you. So really, if we want to think about the earliest descriptions of delirium, we can go back as far as ancient Greece and the writings of Hippocrates, who wrote about delirium, which he described both phrenitus as well as lethargus, phrenitus being sort of the hyperactive presentation of delirium, and lethargus being that of hypoactive delirium. And he described this as an acute disorder, something that comes on suddenly. It's often associated with fever, and it results in people not thinking clearly, behaving strangely, often, or maybe just being very sleepy, as described in lethargus or hypoactive delirium. And in general, it's associated with a host of problems, including disrupted sleep as well as unstable moods. So this is actually, even though this was written 2,500 years ago, a remarkably consistent description of the syndrome that we talk about today. And I want to emphasize something. This is a clinical syndrome. This is a group of symptoms that come together that we recognize as a clinical syndrome. It is not necessarily a diagnosis unto itself. It's a group of symptoms that mean that you've got a clinical syndrome that requires you to actually go further and try to understand what's underlying this syndrome. So in the DSM-5, the key feature is really seen as a disturbance in attention. So the ability to focus one's awareness and It often is of abrupt onset, it fluctuates. It often is associated with new cognitive deficits, including poor memory, disorientation, perceptual disturbances. It's not considered, and this is a confusing exclusionary criteria. It's not due to other neuropsychiatric disturbances such as dementia. What this means is this is something new and different and can't be explained by many years worth of dementia. I will come back to this though, because dementia certainly predisposes you to becoming delirious. So they are often seen together, or delirium superimposed on dementia. But technically, you really need to see this in addition to not exclusively caused by dementia. And then, like I said already, it's really caused by some physiologic disturbance. So an infection or something else, and we'll come back to this. Features that are not part of the diagnosis but important nonetheless, are that almost everyone has a sleep-wake cycle disturbance when they become delirious. Either they're not sleeping at night or they sleep too much and sleep throughout the day. There's often emotional lability and uncharacteristic irritability that you see in patients who develop delirium. The hallucinations are described as dreamlike or oneroid. Often patients will even know that it doesn't seem right what they're seeing. They may have illusions, and they may even have unusual beliefs, which we refer to as delusions. So, and as I've already mentioned, and as Hippocrates has mentioned, people are often agitated or they're lethargic. And it may even vacillate between the two conditions. Or you may see someone at night who's very agitated, and then when you go back to see them in the morning time, they're asleep and lethargic all day. I just want to bring one point up at this juncture, because this causes everyone a lot of heartache. Encephalopathy versus delirium. So encephalopathy is often a term that is used by our neurology colleagues, and we get our knickers all twisted in a knot when we can't actually understand each other. And I think it's really important at this point just to make, again, the distinction between encephalopathy and delirium. They may mean the same syndrome, but they don't necessarily. So delirium, as I've just told you, is kind of a top-down approach to looking at something a patient has. You see this particular syndrome, you say, aha, this looks like a delirium. I need to figure out what's causing it. Encephalopathy, on the other hand, is really a bottom-up approach, meaning our hepatology colleagues or neurology colleagues often will say, oh, this person has an encephalopathy, i.e., let's think about hepatic encephalopathy. Maybe they have slowed thinking, and we know that they have liver disease and they look jaundiced, and we say, oh, this person has a hepatic encephalopathy. In other words, we start with the cause and we see its effect on brain function. That may actually mean that they have the same syndrome. People with hepatic encephalopathy can have an abrupt onset of attention and additional cognitive disorders and all the things we just talked about in the DSM. But it doesn't necessarily mean that they have a delirium. It means that they have something affecting their function of their mind. And generally, encephalopathy identifies a cause from the bottom up. So just wanted to point that out to you, because I know a lot of students and people I work with, and in fact, an international group of us have gotten together to really try to understand this a little bit better in terms of what we mean. And this is the best that I can explain it to you at this point. All right, so what happens when you have a delirium? Why am I giving you this lecture right now? Well, it's very common and it's commonly missed. Delirium is really associated with a number of bad outcomes. It's very distressing for patients and for their loved ones. And what I'm going to try to do is show you a video right now of a patient of mine. This is a patient that I went to see, and I want to tell you, I didn't see her during her stay in the ICU. She had an ICU doctor who was very familiar with delirium, and he didn't consult psychiatry because he knew exactly what was going on. But it was a terrible, terrible time for this poor woman. She was so violent. She bit several nurses, one of whom had to be off on long-term disability. And this was in the midst of her delirium. She was so bothered by these experiences. It was after she had recovered from this critical illness that they asked us to come and see her and talk to her about her experiences. And because her story was so compelling, and I thought it might be helpful for other patients to hear when they'd had bad experiences like this, she agreed for us to make this video. And this is actually posted on YouTube. But here we go. Let's see if you can see it.
My creatinine level from the kidney problem was high, and my doctor at home thought that I should come up and I had a biopsy done. And that's the last thing I remember. The next thing I knew, I was waking up having some very bad feelings and bad thoughts and wondering why I was there and not knowing how I got there. I remember again when I was intubated that I was having delusions. People weren't there. There were aliens there. There were good ones and there were bad ones. And I had a stone crystal, and I had to make sure that crystal got to the right person. And these things were trying to hold me from getting the stone to work. So I still, half of them were human, half alien. And I had to determine who's good and who's not good. And I wasn't finding them. I was just trying to get the stone to where it's supposed to go. And there was a robot in it who, every time I would make a mistake, he would take me back to the beginning again and scan me again. And I had to go through the same process of trying to find out where I'm supposed to be and what I'm supposed to be doing. I know it didn't happen, but it was in my mind. And to me, if something happens in your mind and you see it, it happened. Whether it happened physically or mentally, it happened. My biggest fear right now is not the procedure itself or the problem itself. It's the going through the nightmares. They're terrifying. Someone should have to go through that. Talk to them, take time to see what they're trying to say. Keep diary. I'm going to ask you about what went on, and I want someone to be able to tell me when. And it's better if it's written down, just soothing words, soft music, something soothing, because I'm probably fighting a battle in my brain.
So that, let me see if I can get back to my screen here. So that actually, this website here, just for your information, is a group that I am part of in the pulmonary critical care department of our university. And this is actually a very rich resource for all sorts of opportunities for people to learn about delirium, but also about critical care and how we can actually do a better job for patients. And this is one of many videos that we have there. And so I really encourage you to explore this resource. I noticed that we had some pediatricians in this talk as well. we actually have a very large endeavor in our pediatric intensive care unit around some of the very things that I'm going to be talking about for adults, because delirium actually does affect children as well as adults, and it does also have very bad outcomes. It signals bad outcomes, as I'm just about to talk about here. So why do we care? Obviously, the video, at least for me, I don't know if you could hear and could appreciate, but this woman who came in with sepsis, she actually had chronic kidney failure, and she had a kidney transplant, and that's how she got to the ICU. She had this terrible delusion where she believed she had this stone that she had to get to somebody to save her, nephrologist of all people. And, you know, that's why she was biting the nurses. I mean, she, of course, didn't think the nurses were there. She thought she was in the middle of some terrible conspiracy, some sort of robot conspiracy. But you can really feel, and I bet you know family, or maybe you've experienced some periods of delirium, maybe you even remember from childhood, because children actually are very prone to delirium, as are older people. You can remember how terrifying it can be when you are delirious. And it certainly is very distressing for people most times. Sometimes people have pleasant experiences, but even those, people say later, oh, it was so strange, I don't generally want to feel that ever again. So in addition to just the distress that it causes, it's also associated with really significant increases in healthcare utilization. And this is in part probably because it is associated with bad outcomes, just as Hippocrates told us a long time ago. So, you know, there's increased mechanical ventilation, increased length of stay in the ICU, length of stay in the hospital overall. So, of course, you have increased costs. And so there is no doubt that it is associated with some bad outcomes, including a higher risk of death. And there, it seems to be certainly a relative risk of maybe twofold, even when you adjust for all the severity of illness factors. Much higher rate of death when the person is delirious. But interestingly, and this is work done by a colleague named Margaret Pisani, if you look over time, you can see that the longer the delirium during the index period, the higher the risk of death, up to a year and beyond after hospitalization. So it's certainly flagging bad outcomes for us. It also has been interestingly associated with increased functional decline, new nursing home placement in our setting, as well as persistent cognitive decline in those who experience delirium. And this is work that was done by Pratik Pantarapandi, who looked at people's cognitive function out to 6 months and a year after ICU stay. And you can see actually that the more days of delirium during the index hospitalization, the lower the cognitive function. And this is an R-bands, which is a particular type of cognitive test that we use. But this is really in line with people who have even a dementia. Work that's been done in the community suggests that it's that even in people with dementia pathology, the presence of delirium actually results in a much steeper decline in cognitive function, this time using a mini-mental score in patients who live in the community. And for those without dementia pathologic burden in their brain, the presence of delirium does still seem, this is actually, you'll have to take my word for it, but this is a steeper slope than this one. And you'll notice people with delirium start out at a lower cognitive level in all of these studies. So that brings me to discussing predisposing and precipitating factors of delirium. Who gets delirious? Well, we find delirium in the hospital setting, certainly in those places where people are critically ill. Those individuals have the highest likelihood of developing delirium. So you can see these numbers are very high amongst mechanically ventilated people, In general medical units, depending on the kinds of patients who've been admitted, you may have prevalence as high as 40%. On oncology units too, again, depending on how sick people are. In orthopedic units where patients tend to be older, we have a relatively high prevalence of delirium. And why the variability? Well, as I've said, probably the sicker the patient and the older the patient when talking about adults, and predisposing cognitive impairment that someone may have, as we saw in some of those graphs earlier, the more likely that somebody is going to transition to delirium. And this, again, has been documented in many studies. I've just shown you one example here from another paper by Pratik Pandharpandi. So, yeah, probably you know this already. The more ill the patient, the greater the likelihood of delirium. So Sharon Inouye actually wrote a lovely paper in JAMA a long time ago already, looking at the interplay between who the person is, the baseline predisposing risk, and the kinds of things we do to patients in the hospital to make them delirious, precipitating factors, or things that happen to them, maybe illnesses that they have. So who the person is, I've just said this, but I'm just going to reinforce this once more. Baseline cognitive impairment, very likely to me. So people who are demented, for example, much more likely to become delirious. Or people who have an underlying, some other kind of underlying intellectual disability, maybe lifelong, much more likely to get delirious. People with chronic medical conditions are much more likely to get delirious. Folks with visual, hearing, functional impairments, people who use alcohol or other drugs are much more likely to become delirious. And the more of these factors that you have, the more likely that they will become delirious. So we want to target high-risk patients to make sure we watch and see whether they are getting delirious. So what are the precipitating risk factors? Well, medications is a big one. So new medical illnesses, new infections, COVID, for example, is quite, the type of infectious disease that often is associated with delirium in very ill patients, at least. Other types of infections, bacterial infections, viral infections, and of course, as we've already alluded to, alcohol and drug withdrawal might be the precipitating risk factors that make someone delirious. There's also fluid and electrolyte abnormalities, and dehydration very commonly can cause this problem, particularly in people who already are fairly frail, urinary retention and fecal impaction. Probably one of the most important things that we do badly in our hospital systems is that we keep people in bed. There's probably nothing worse that we can do for a human being but force them to stay in bed. And for years and decades, it's been our practice. So reducing people's immobility and really trying to make the environment such that they have to get up out of bed, that they're allowed to sleep at night, but are kept awake during the day. Really important. Physical restraints are another reason that another way that we can immobilize people. So when people are violent and aggressive, of course, sometimes we do have to use restraints, but it really should be a last resort. We should be using creative ways to get them up out of bed and moving around. Indwelling catheters and uncontrolled pain are also other things that have been seen as responsible for making delirium more likely. And of course, depriving people of sleep is really something we do a lot of in our hospitals because it's noisy and we're not always respectful of the need for sleep, particularly in very, very ill patients. If you were to read one article, if I were to somehow interest you in this whole topic, the article that I would really encourage you to read is actually an article that came out in 2020 by Joanne Wilson, a colleague of ours, many of the people who are interested in delirium around the world actually contributed to this article, and it's in in Nature Review's Disease Primers, and it's a review of delirium. This is basically a compilation of this is a figure from that article that really compiles all of these factors that may contribute to delirium. This is a really great article, and it really reviews the pathophysiology as well as what we know about what works and what doesn't work in delirium. And I would highly recommend this article to you. And in fact, I'll send it along in addition to a PDF of these slides so that others can read this as well. I think it's really helpful. So what is the underlying pathophysiology? And again, we don't really know, but here are what some of the thoughts are. Fundamentally, we think that delirium is a generalized response of the brain to systemic triggers. These systemic triggers probably it can be quite variable. They can be due to acute inflammation. They can be due to hypoxemia or reduced perfusion or metabolic derangements. And we think that these sorts of triggers can have impacts at the neurotransmitter level. They can actually have cellular impacts on microglia as well as astrocytes. Certainly, this can result in vascular dysfunction and neuronal network decoupling, as it were, and synaptic changes. I'm really just giving you kind of a big high level overview because we don't really have time to go in the evidence for this, but again, this Wilson paper is a really great resource. And Colm Cunningham probably is one of the few mouse model delirium researchers who's done a lot of work in thinking about delirium and trying to put these mechanisms together. So I would highly recommend this paper once again if you'd like to, if you're curious and you'd like to have a little bit more information on this. But at any rate, it's brain failure and it's caused by some sort of systemic trigger. And that's the important thing for you as a clinician to figure out what is that trigger and how can we correct it. So that brings me to prevention and management of delirium. What can we do? Well, first of all, we've got to identify it. And it's interesting because depending on where you're working, depending on the expertise of your nurses and the culture of the place, it's often missed. And it's missed even when we spend a lot of time trying to educate people. And it's especially the hypoactive presentation that gets missed. And this is understandable. It's often misdiagnosed as depression or psychosis. It's not unusual for me to get a consult saying this 72-year-old woman is having her first break of schizophrenia. And I say, really? That's interesting, but I doubt it. I think it's probably my highest thing on the differential is going to be an episode of delirium. So delirium also trumps all other psychiatric disorders. You really can't make a diagnosis of depression or anxiety or anything in the midst of a delirium. That mental state needs to be clear before you're talking about any of those other diagnoses. It's often missed because, and I miss it too in patients if I'm not actively testing cognition. And you can imagine if you walk into a room and you say, Mrs. Smith, how are you doing today? And if she sort of opens her eyes a little bit and just says, okay, and you walk out of the room and say, yes, she's alert and oriented and fine. If that's the extent of your exam, you can easily miss a delirium unless you're actively engaging the person and testing cognition. And as we've said already, because it can co-occur with dementia, sometimes if we don't know what somebody's baseline is, it's very easy to miss an acute change. So how do we identify it? Well, the best way is, of course, to talk to family members who know the person. The individual themselves may not have any insight and often don't have any insight into the delirium. when they're in the midst of it. I did show you a video of somebody who had great insight into what they had after the fact, but the point is you need to be seeing them during it. And during it, people don't generally have much insight into what's going on and may not make much sense at all. So what you want to do is you want to find out, what's your granny like at baseline? What is your mother like at baseline? What was she doing last week? Is this the way she is at baseline? And if they say, no, 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 this is completely different, then you know that you have an acute change. So you're looking for fluctuating levels of consciousness. So somebody may be okay, and they may be talking to you appropriately, and then all of a sudden when you're talking to them, they fall asleep in the middle of conversation. That is not normal. We don't allow that. That is not normal, and you better be thinking about delirium if that happens. And if you say to yourself, oh, well, it's just the medicines we're giving her, then stop the medicines, because it's wrong. Person shouldn't be falling asleep mid-sentence, unless of course it's the middle of the night, and in which case you shouldn't be talking to them. You should be letting them sleep. So also we want to test their cognition. We want to find out if they're oriented, if they're able to recall information. Are they able to pay attention? So for example, are they able to do tasks that allow divided attention? So something, for example, we often use asking people to say the days of the week backwards, or say the months of the year backwards, or spelling a word, their name, backwards, because it's not it takes a little bit of attention, not that much, but it does stress that ability to focus and divide one's attention between a task. In other words, identifying the letter and saying the one that comes before, or the month, or the word. So we also want to know about testing short-term recall at a minimum. And so putting this in your mental status exam or your neurologic exam is really, really important in order to understand where somebody's baseline is and whether they've had a decline or whether they're improving. You can use an EEG, and sometimes the EEG can be helpful. A slowing of background rhythm can be seen in various kinds of metabolic causes of delirium. Unfortunately, it's not really 100% sensitive, and it's not all that specific. And so we don't advise this as a first stop. Really, the first stop is getting a history and doing the clinical exam. And so really trying to identify the etiology of delirium is then the most important part of identifying delirium. So starting to go through your differential diagnosis and looking for an underlying cause that may be the systemic trigger of the mental status change. So let's see. Is this your granny? For me, is one of the best questions to ask grandchildren when their grandparent is in the hospital. And if they say that this is very different, it really helps me understand that there has been a mental status change. I ask about things like, are they starting to take new medicines, over-the-counter medicines? Things, do they have a cough or a fever? Have they had infection? And as I've mentioned already, but I just want to make the point to you, actively test somebody's attention. Don't just say, how are you? Say, can I test your attention? Can I ask you to do a couple things for me? Can you start with December and say the months of year that come before? Or find something appropriate for your setting, for your patient, that you can ask them to do that stresses that ability to toggle between tasks, to attend to a task. So these are some of the things that I use. Orientation, these are the kinds of things that I use to test orientation. And as far as recall is concerned, I often start at the beginning and say, I'd like to test your memory now. I want you to remember these 3 words. I give them 3 words. I say, look, can you say those back to me, and try to get them to say back. Often delirious patients can still register. They can say the things immediately back. But what I ask them to do is to try and remember it, that I'm going to distract them. And oftentimes there is very, very little ability to learn. And that makes sense, because if you can't attend, it's very hard to actually retain something. So there's also one other thing. I mean, I think I teach my trainees to either use the MMSC or the MOCA. The MOCA is a little bit harder for people, and so we tend to use the MMSC. There's also another delirium screening tool that's been developed by my colleague, Alistair McCulloch, that is a really nice tool because it pays attention to the arousal level of a patient. So when I said to you, we don't want people falling asleep in the middle of a conversation, a lot of times that patient gets overlooked in delirium screening tools because they are not testable because they're falling asleep. Well, in this test, which is called the 4AT, the very first item is really the level of arousal. And so your task when you're using this instrument is to give the chance to the patient to get fully awake. So you can set up the head of the bed and say, hey, Miss Smith, I want you to stay awake for me. And you try to really engage them, give them their glasses, give them a full opportunity to get engaged in the interaction. If they can't stay awake for even 10 seconds, if they're falling asleep in the middle of the conversation, that is a 4. And that is basically the cutoff for this screening tool that says, oh, this patient might have delirium. So just falling asleep in the middle of a conversation will actually get you a 4. Of course, there are other ways to get more points on this, and you do actually have to check with family members to see if this is a difference in terms of their presentation. But it's a great tool, and we actually have included this in all of our patients who are admitted to our health system who are 65 years of older and in the hospital. So the nurses do this once a shift. So this is a great tool, and it's free of royalties and copyright infringements and all those problems. Alistair McCulloch is a wonderful person who's been funded by the British healthcare system for the development of this tool. So how do you treat it? Well, as I've said, while this is a psychiatric presentation, a clinical syndrome, it's due to an underlying medical problem, and we really need to find and correct the cause as our primary approach to treating the delirium. There are lots of memory aids to help you think about the differential diagnosis. This is one such memory aid that I've talked about, and I've already alluded to a lot of these things. This differential diagnosis will also be determined by your practice setting in which you work in terms of the most likely things that cause problems. In our setting, we have a lot of alcohol and drug use disorders, and so that often is very high on the differential, and benzodiazepine withdrawal being one of them. We also have nutritional deficiencies, a lot of thiamine deficiency, a lot of micronutrient deficiencies that we need to think about and need to treat early. And that may be the case in your setting as well. But particularly when people are using a lot of alcohol, it can compete with thiamine and other micronutrients. Probably most importantly, though, instead of talking about the differential, is I want to talk about pharmacologic strategies. And I think what I want you to take away from this is really do no harm. And what we've learned is that minimizing drugs associated with delirium is probably our best bet, particularly in those patients who are critically ill. And of course, we always want to know, can we prevent delirium with medicines? And that's really been the holy grail of research. This is an old article, but really it's not really advanced. There really is no agent. These are the agents that were studied in this particular article, but there's no agent that can consistently prevent or treat delirium. A lot of people want to use haloperidol with antipsychotics. This is a review that we've done more recently. Again, haloperidol and other antipsychotics do not prevent delirium based on our studies. Now you might say, well, this isn't crossing zero. Maybe it is. Second generation antipsychotics at least technically, if you only clump these 3 studies together, maybe it looks like there's some preventive function of these agents. But let me tell you, these are very small studies. And I'll bet you if we do a big systematic study, there'll probably not be any preventive benefit to 2nd-generation antipsychotics. Certainly, there's no evidence for haloperidol. It's solidly around 0. So it doesn't look like antipsychotics prevent delirium. And also what I can tell you is they do not shorten the course of delirium either. So what we do know, though, is that exposure to medicines like benzodiazepines such as midazolam or other agents like Ativan, people who are exposed to opioids such as fentanyl have a much higher risk of developing delirium in the ICU than those who are not. And here's the lorazepam data that I just mentioned. So with increasing doses of lorazepam, you see an increased probability of transitioning to delirium. So what we've done in our ICU and many ICUs in the US over the last decade is that we've really tried to change the script. We have decided that people, even if they are, this gentleman actually was admitted to the ICU with a really bad, a really bad pneumonia. He's intubated, as you can see, but he is alert and awake. We avoid infusions. We try to just give pain medicines to help be able to tolerate the ET tube. And oftentimes people don't really need it for that long. They can really begin to tolerate the ET tube without a whole lot of pain management. And certainly they can remain alert and awake. This is probably one of the best delirium prevention strategies in our hospital, is really not using a lot of benzodiazepines and not using a lot of pain medicines if we can get away without it. And what, and I'll get back to some of the non-pharmacologic interventions, but just to take away the message on drugs is really, we don't have anything to prevent delirium. What we do have is stopping medicines and making sure that we don't expose people to a lot of medicines that might result in their delirium. And there's actually some studies still ongoing. Melatonin has been an interest of mine and others. In my hands and some other investigators, we really don't have much of a signal in postoperative older patients or melatonin agonists, specifically Ramelteon. However, the jury's not out. There may be some subpopulations that in whom these sorts of things work, but I don't have that information for you yet. Most importantly, though, are the non-pharmacologic strategies. We want to really make sure that we are stimulating people, that we are getting them up and out of bed, that we improve their sleep, and that we do all of these things, all of this fantastic care. We want to bring that to everyone in order to prevent harm, the harm of prolonged hospitalization and delirium. So this is that same gentleman I was showing you. He's actually one of the very first patients that we use these protocols in the ICU. And I think that mobility is key. Now, in order to be mobilized, you have to not be sedated. So just want to emphasize again, we want to stop all of our sedation as early and as soon as possible. We want to get people up and moving. We want really, and this is all for the purpose of improving their outcomes. And it seems that this is probably beyond this conversation, but it is important to note that mobility has its greatest impacts if you do it early in the stay. So just like I showed you, the gentleman who was admitted with the pneumonia, we want to get him up and moving around as soon as possible. It is the best thing for patients. We also look at sleep, and we did a little intervention in the ICU, really trying to improve sleep at night. And we did that through changing environmental factors as well as really tailoring sleep for each individual in the ICU. And we were able to show that we were able to cut down the number of delirium days in the ICU for patients. So when you look at studies that have combined sleep, mobility, all these kinds of interventions where we want to bring rehabilitation to patients early in their stay, we actually find that we can probably prevent about a third of delirium, both in the surgical settings and the medical settings. So 2/3 of delirium we're not preventing. So we still need to be aware of it and try to reduce the length of the delirium through these multi-component ways. But I think it's really important to do these multi-component interventions early in the person's stay, and we can then begin to reduce the burden of delirium and improve outcomes. So I just wanted to show you some pictures since I don't have a video of this. These are some of the ways that people are implementing cognitive stimulation in the ICU. So having people read newspapers and books, and when you walk through our ICU, you will see patients are generally alert and awake on the ventilators, and we are getting them to do things like read, do Sudoku, have them up walking with PT out in the hallways. And it does take a lot of effort because you've got to make sure that you do it safely. Having them outside in the sunshine seems to be very important for diurnal regulation. And for those who really can't get out of bed, we have these bicycles. So we have bicycles that we can put in the bed that they can actually pedal. Sometimes when we have really agitated patients with delirium, we'll actually get this cycle out and put it in their bed and tape their feet to the pedals and just get them to release some energy by getting them to pedal. And we had this one patient who said, yeah, I don't remember that much, but I just remember your voice saying pedal, pedal, pedal. So I hope that's not harmful, but we believe that it's good for the brain to have increased mobility and activity. And so for that reason, and certainly this intervention seems to be the one thing that shortens the length of delirium. And we call this WEHAB because they're using the we, and patients love this. They really get into this. And then we don't have this, but colleagues in Germany actually have a pool that they take critically ill patients into and have them move around and call it hydrotherapy. So in summary, prevention and treatment, we really need to detect it. We need to be aware of patients' baseline, correct those underlying causes as our very first approach. So differential diagnosis is critical. Really doing no harm by reducing delirium causing medications, reducing sedation so that we can mobilize people, so that we can engage them in cognitively stimulating activities, and improving their sleep are probably some of the most critical interventions that we can do. And I just wanted to end there and thank you for your time and my going on at some length about this. And I think we have some time for questions, at least 5 minutes by my way of thinking, and I'm available. So thank you. So are there any questions about this area?
Thank you so much, Dr. Karin. I'm called Kwagala Claire. I'm a resident, third-year resident, doing psychiatry.
Great. Oh, nice to meet you. So have you seen patients with delirium, or are there questions that you have?
Yeah, I have. And some of the interventions are very interesting. However, most of them in our setting here, for example, the ventilators, we don't have any mobile ventilators that even if you wanted a patient to, be mobile, there's no way you could do it. And I don't know, most of our patients that have been on the ventilators eventually need sedation because they are fighting the ventilators, maybe because of our interpretation of machines in our culture. Every time a patient is on the machine, they think they're going to die.
That's not different here. Yeah, that's not different here either. So I would challenge you. In fact, we had no mobile stands either. What we did is we went to our engineering students and we said, we need a way to be able to move our ventilators. But let me take this even out of the ICU, because I think we're very ICU heavy and your hospital is probably not nearly as ICU heavy. You have a much younger population, so you probably don't have as much need for ICU beds. But let me just say that all of these interventions are very applicable to medical units as well. So when you have a fighting, agitated patient, instead of tying somebody down, I realize that sometimes we do have to do it, but if you can, get the person awake, get them up, get them moving, get them to the toilet. Oftentimes people who are agitated just need to sit on the toilet. So get them to sit on the toilet, start talking to them, start engaging them, start telling them, look, you don't seem to be yourself. I think something's wrong. So the point is, I hear you. Exactly what you're saying is what every single nursing group always says to us. Oh, we can't do this. Well, actually, every patient fights a tube down their throat. But if you can get them awake and alert, and you can use some haloperidol to get somebody to kind of calm down a little bit so that you can actually intervene with them. But the point is, you're not using the haloperidol to actually change the course of the delirium. What you're trying to do is you're trying to give people cognitive stimulation and reorientation and get them to settle down a little bit, meet their needs, get them mobilized. But that's my big message, is that, yes, I know you think you can't do it, but yes, you can. You're saying nothing different than any of the nurses that we've ever dealt with. So my job is to challenge you.
Thank you very much. And we are challenged, Dr. Neufeld. This is normally Naka Suja, Head of Department Psychiatry. Thank you so much for this enlightening talk. My question is on dealing with delirium in patients that have dementia, who oftentimes have other comorbidities like hypertension or diabetes.
Right.
And it's kind of challenging to figure out what insult of all these that are ongoing is probably causing this delirium, which tends to kind of become chronic sometimes. So your insights into this would be very helpful.
Yes, in fact, somebody with delirium, it takes very little. I mean, somebody with dementia, say an Alzheimer's dementia, it takes very little to make them delirious. And so I think we generally start with, I think you've heard from Paul Rosenberg in the past, my geriatric colleague on the consult service. We really try to think about ways to both environmentally, but also from all of the things that can be occurring, try to think about all of those triggers that might in fact be at play. I think, for example, what new medicines have we started? Has there been some new medicine? So even things like a small dose of benzodiazepines can be quite anticholinergic for some people and can make them very delirious. So pulling back on whatever is anticholinergic, particularly if you're dealing with somebody with Alzheimer's dementia. So I tend to try to pull away all medicines just in case it's some combination, some new combination or otherwise. It may be that there are a couple of things going on. So is the person dehydrated? Are they drinking enough? Are they eating enough? Do they have some low-grade infection somewhere? Are their teeth infected? A lot of times we don't actually examine dentition, but for us, a lot of times patients have old occult infections or abscesses that might just be enough to provide sort of this low-grade delirium or low-grade infection that is resulting in the delirium. And then I think as far as the environmental things, it's really important to try to protect that sleep. So trying to get it quiet at night, having somebody who is familiar to them be with them. And maybe that's something that you do already, but we're trying to do much more frequently, but it's made difficult by things like the pandemic where we've had to restrict visitors. But these are the kinds of things that I think I go to first in these older patients who already have an underlying dementia. But you're absolutely right. And oftentimes it's a couple of things that might be going on at the same time.
Thank you. Does anyone else have any question? I know we are over time. Yes.
Yes.
Can we, Dr. Neufeld, I hope you can take a few more questions.
I certainly can. Yes, I don't
great.
have. Yes, sure.
Right.
Okay.
So,
Yes.
Okay.
Hello.
Abona, please ask your question, and then Wamala.
Okay. Thank you very much, Doctor. I wanted to, for patients, for patients who have had delirium before, do they have, are they predisposed to any major complications in the future? Because I realized one of the risk factors to someone getting delirium is actually having a previous episode of delirium. So are we supposed to, is there like a follow-up that we can follow for these patients, even if it is a temporary state? Is there something that we can be watching out for? Thank you very much.
Yes, thank you. It's a fantastic question. Yes, I think actually if you have and we're talking about adults right now, so if you end up seeing somebody in the hospital who gets terribly delirious, I think it's probably one of the most important questions that comes up in my mind is this person actually going to develop a dementia in the next several years? A lot of times, I think at least we find that the patients who are getting delirious, newly delirious in the hospital, or perhaps they've had a delirium before, seem to be at risk for future decline. And I showed you a little bit about, the number of days of delirium and that they're much more likely to have cognitive impairment even a year out. So I think actually watching cognition is very important over time. So if you are able to get a primary care doctor to monitor, or primary care setting clinic to monitor the patient over time to look at their function, I think that that's important. I think the other thing that's important to us as psychiatrists is just like the video that I showed you, that woman was terrified of what had happened to her. She was so terrified that she would fall into delirium again. It was frightening to her. And I've had so many patients that say that this is the worst experience of my life. I never want to go through that again. It was so terrifying for me. So I think as psychiatrists, I think it's really important for us to listen to our patients. And, you can always share these videos with patients as well to show them that they're not alone. And if you collect some videos of your own patients, you might want to actually share it with others if you get their permission to do so. I think it can be very helpful for people to realize they're not alone, that this is part of a medical condition, and to comfort them in that way. So I think supportive psychotherapy is really important for patients who've had these terrifying experiences, because it stays for a long time, the fear, and it can be quite crippling.
Right. And I think to add on to that is what you also presented earlier, that the risk for death in these kinds of individuals, even up to the 1 year time point, is usually more than the general population, possibly because they may have maybe other ongoing conditions, and therefore whoever is managing has to be careful, much more careful in looking after whatever it is that they may have as underlying conditions.
Yeah.
So there's a question for you in the chat
Yes.
that's saying Wamala David has noted that some patients with delirium who may have had chronic subdural hematomas as the underlying cause. Is it prudent to have a low threshold for doing brain CT scans in delirium patients?
Interestingly, I reviewed a paper some years ago that looked at all the CT scans. I guess it depends on where you're practicing, but this was in North America, and the vast majority of people, nothing came up on CT scan. Now, having said that, I suppose that if we have a history or evidence of trauma to the head, that would be an important person to do a CT scan on to see if there is a subdural hematoma, because it's very common to have delirium associated with head trauma that results in some sort of brain bleed, obviously. So to tell you the truth, if there's no evidence of trauma to the head and there's no clear lateralization on neuro exam, I don't even encourage my house staff to get CT scans until much later in the investigation. If we really can't find anything, then maybe we do it then. But I don't think it's as big a value given its expense.
So anyone else with any last question?
Yes.
Yes, Wamala?
Yes. Thank you very much, Dr. Karin. I'm Wamala, I'm also a psychiatric resident. Well, about the diagnosis, I was inquiring, because when you look about the diagnostic criteria, you've talked about the attention and arousal. I'm seeing it as it would be hard to pick in children. I was wondering if you had any experience in the children.
We do. And in fact, in that OASIS website, I think we have a lot of resources. There is a pediatric intensivist by the name of Sapna Kujarkar, who has developed and other colleagues throughout, actually in the United States, that have developed two confusion assessment method approaches for pediatric patients. So they have a pediatric CAM, and they actually even have an infant CAM. So, you know, and this actually you can use in really severely demented patients too, I think, although I haven't tested this like in a rigorous way. But basically holding up a mirror to the baby and having them and showing the mirror is one of the attention tasks, and seeing if they can track their own image in the mirror is one of the attention tests. So yes, there are instruments used in the ICU to try to look at arousal and attention in infants and children. And there's just been a whole lot of work around this, because one of the things we realized just even a few years ago is that in this country, ridiculous stuff was going on. We're giving huge amounts of benzodiazepines and opioids to children. And in fact, they get so dependent on these medicines that these kids were going home for up to 6 months with methadone and, you know, other long-acting benzodiazepines to help them with withdrawal. And it was pretty clear to us we needed to stop this, because just like in the adults, we don't need this stuff. We really can manage people awake and alert and mobilize them and have much better outcomes. And so too, this whole wave of change is coming to our pediatric intensive care units as well. So great question. And yes, you can find, there are a number of instruments that you can find on the web that you can use in children and that have been validated.
Right, so it is 10 past, we've already gone beyond the hour. We really would like to appreciate the time that you have spent in preparing this, and for sharing us the new move towards you know, the management of delirium. And we take on the message that, you know, get them more active, try to, you know, keep them doing stuff, and minimize on the antipsychotics, which we have been running to. And the benzodiazepines, will do the best that we can in the setting in trying to manage these conditions. But we thank you for the new insights into managing delirium.
Thank you for
very
listening
much.
to me. Yes, thank you. Have a good day.
Have a good day.
All right. Thank you.
Bye-bye.